Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, my guest is Dr. Stephen Olmos. Dr. Olmos earned his DDS from the University of Southern California School of Dentistry and is board certified in both chronic pain and sleep breathing disorders by the American Board of Craniofacial Pain and Dental Sleep Medicine. He has dedicated over 40 years to private practice, devoting more than 30 of those years to researching and treating craniofacial pain and sleep-related breathing disorders. In 2023, he retired from clinical practice to concentrate on advancing these fields through education and research. Dr. Olmos founded TMJ Sleep Therapy Centers International, which now includes more than 85 licensed locations throughout the world, exclusively dedicated to diagnosing and treating craniofacial pain and sleep disorders. He continues to lead the field by teaching his innovative system around the globe and regularly publishes research on the connection between pain, airway, and sleep disorders. He is also the author of the book Airway Management, A Solution for Our Health Crisis, has published dozens of articles in leading professional journals, and lectures around the world on the topics of sleep, airway, TMD, the oral systemic link, and craniofacial pain. We are going to discuss his amazing journey and why he decided to make the treatment of craniofacial pain and sleep-related breathing disorders the focus of his practice and his teaching. We'll also get into some of the struggles he's endured throughout this endeavor, his diagnostic processes and how he approaches patient care from a medical and holistic approach, his thoughts regarding why dentistry is still focusing on treating symptoms and not addressing root causes, the role that sleep and breathing play in facial pain, how we can change the way that care is delivered to our patients going forward, and much, much more. Whether you're a professional or a layperson, this episode will change the way you think about the profession of dentistry and its role in pain and airway management. So without further ado, let's get on to today's episode with Dr. Stephen Olmos. Enjoy the show, everybody. Welcome to Doc Podcast, Steve.
Thanks, Mike. Thanks for having me.
It's my pleasure. Thanks so much for coming on. We were just talking before we started recording here that with our busy schedules and both of them picking up quite a bit in the fall with lecturing and coordinating with travel, especially with you, as we're going to talk about quite a bit during the show. But I really appreciate you taking the time to sneak this in and make the time for my audience to be able to talk about what we're going to talk about today.
Yeah, I'm excited. We had a great conversation earlier, and it's amazing how paralleled a lot of our history is. So, yeah, really happy to share it with other people.
Yeah, no, I'm really looking forward to it. And I agree. Yeah, it's so many parallels. And that's part of the fun in doing this is getting to meet and speak with people such as yourself. And I want to thank Liz Walker for putting us in touch with one another and introducing us to one another. And that's how this grows. You just keep meeting people and speaking with people. And when we did speak a little while back and we're just chatting, your journey is fascinating. And as my audience knows, I love hearing people's stories and the history of where they got to be where they are. Because as I always say, people see you as the Dr. Stephen Olmos that you are today, but they don't know the Dr. Stephen Olmos that you had to become and evolve into to be the guy that you are today. So if you would take a moment, just share with the audience, you can go back as far as you want, just a little bit about your journey. How did you get to the point that you're at in your life and your career today?
I started out in 81. I graduated from SC Dental School, USC. And I guess that doesn't define it. University of Southern California. and yeah, grew up in Los Angeles, came down to San Diego, here where I've lived since then, and did general dentistry for, I don't know, about 12 years or so. And then looked at all the phases of dentistry that we can do with general dentistry. But there was one telling part is that no one seemed to know what to do with these people who had chronic facial pain and jaw problems. And it was pretty frustrating. I thought it was just the general dentist because we rotate through different specialties in dental school. But the section on facial pain was really not impressive. And I came away with, is that all we've got? And it came out, and then I thought, it must be just us general dentists that don't know anything. So I would refer to the oral surgeons. And back in the day, in the early 80s, mid 80s, there was a lot of surgery going on. There was a lot of disectomies, a lot of different therapies and condylectomies and all kinds of stuff. And I came to find out in trying to help these people that it didn't work then. It's kind of sad where pendulum's kind of coming back, where we got away from that, but it looks like the door's kind of opening again. And it was really sad because, so I tried the oral surgeons. The people didn't get better. I thought it must be the orthodontist that no. I sent them to orthodontists and they didn't get better. And I thought, oh, it's probably the prosthodontist. So I sent them to prosthodontist. They didn't seem to know. And so I just started taking classes and tried to get some understanding, some background, join some organizations and things, and just put some focus into it.
Because you're seeing these patients, it's not working. Is that why at this point you're just searching for answers?
Yeah, these poor people. And we're a Navy town, and we got a Navy hospital here. And some of these young girls that were coming out of total joint replacement surgery with narcotic pumps in their spine and just demoralized. And you realize that this person's not going to have a life, that they're never going to get married. They're never going to have kids and a family because they're just in such horrible pain. And this is how they were left. And they were like in their 20s and stuff. And I'm just, oh my God, there's got to be a better way than this, you know? So anyway, I was just really stimulated to see if anybody had answers for this. So I looked at basically every philosophy that exists in dentistry and medicine. In chronic pain. There used to be an organization, International Association of Pain Management, which I thought was a really good organization because it was basically anybody that treated pain. They'd have, it was one of the largest organizations, I don't know, 8,000, 10,000 people. And they'd have these meetings and maybe 10 lectures going on at the same time, and you're sitting next to a neurosurgeon on one side, chiropractor on the other, whatever, as a dentist, just sitting through all these different lectures on everybody trying to help people in pain. So I thought those were really interesting. I became a diplomate of that organization before it went away some years ago. But I just love that collaboration. And looking at it from a medical perspective, because all the dental therapies, they don't really make sense to me, and they didn't really hold up. And believe me, I'm a diplomate or fellow of every philosophy you can think of. And
you literally are. When I was doing your bio, you literally are. It's amazing what you have achieved educationally.
So I practiced for a while, being in this limbo. And I finally came to a point where I just needed to make a change. You know, I just needed to not do dentistry anymore. It became kind of rote for me. And so I decided that, crazy enough, that's me. I guess my personality, I never tell anybody to do this at this point in my life. But I sold my dental practice and I decided I was going to learn this stuff. So I locked myself in this room that we're in, that I'm coming to you from right now, for a good, 14 hours a day at least. And I would read. My wife would put food underneath that door over there, make sure I was still alive. And I just went back and studied all the basic sciences again, the physiology, the anatomy, the biochemistry, all the component parts, the neurology, the pharmacology. But I learned it this time from the medical perspective, not the dental perspective. You know, I already went to dental school. I already took all the dental certifications. I really wanted to understand these things from a medical perspective, because in reality, these are medical problems, you know, musculoskeletal pain, orthopedic pain, neurologic pain, respiratory disorders. Those are all medical problems. And I think that's why dentistry doesn't really have good solutions for it. So that's what I did. I did that for like a year, and I rented one of the operatories from the person I sold my practice to. And I treated patients, and I had a staff that I trained and sent them all over the country getting training and information. And yeah, it was really hard because I had to tell my wife that, I have to sell this successful practice that we owned outright, and I'm going to sell everything, and I'm going to start a new business. And she was like, yeah, so she was incredulous, right? She's like, well, let me get this straight. So you want to sell this business that we own, is doing well and everything, and you want to put all those saved monies into building this other and training and everything else and training the staff. And you want to make a business that you don't even know if it's going to work. You don't even know if people are going to refer to you to make this work. And I was like, yeah, that's right. And she said, oh, by the way, I'm pregnant. I'm like, oh, okay, great.
Oh, so, wow. Now, about how far into your career are you now when this is happening?
So
how many years-ish?
So that was like 30 years ago. So I was like 40 when I made this. Yeah, so I guess I had been practicing for about 14 years. And
so enough to have seen and done a lot, obviously. It wasn't like you were a neophyte in this and just, I don't really love this. Yeah, you had been living it for a while. Yeah.
Oh, yeah. And I saw that as my future. And I was like, I really wanted to be challenged. And I can't think of anything more difficult than pain. Chronic pain is the most complicated, especially of medicine, including dentistry.
Have you or a loved one suffered with pain, if you don't mind me personal to you?
It's really interesting. I actually feel blessed that I've had most of the things that I've treated people for, but I didn't get into it for that reason. And honestly, early on when you're young and you're doing things, I was very active. I did a lot of endurance stuff and triathlons and marathons and stuff. And I didn't realize I was a sick person. And but there was many days I would have to call into the front office and cancel my patients because I'd have a migraine that I just couldn't get out of bed with. So I didn't set on this pathway to fix me. But it was interesting that as I learned to help other people, I actually learned what works and what doesn't work, and from a patient perspective. And so I broke my jaw. I fell, fractured my jaw, had to have a closed reduction, mouth wired shut. And I've been through a lot of the stuff that people have had and I treat people for. And so it was a good learning experience. So in the end, I've resolved myself of all the things. It turns out I have severe apnea. Most people wouldn't guess that looking at me. I'm pretty thin, but yeah, I have age, I have 30. That resulted in high blood pressure, and I had to look at diet. I had to look at the big picture, for which I do for all our patients in a comprehensive way that we treat. And I was able to fix me. So weird. I'm actually a healthier person now at 70 than I was in dental school. When we were doing those first exams to get into dental school, I had high blood pressure then.
Wow.
And so it's kind of funny how people just expect aging to produce dishealth. But I like to use myself as an example of that's not reality. Certainly, you have less growth hormone, you have less muscle mass, you have less. But I can still do stuff. I still ride my bicycle on the hills here where I live, and I'm still active. And I don't think age is the limiting factor in that equation. Yeah. So I just locked myself in here, and I read and I studied and I took everybody's board exams so that I could prove to myself that I understand the material. And then I basically saw what worked and what didn't work. And I kind of pieced it together as to what consistently worked. Because to make a living doing this, you have to have consistent success. You can't have, because the average of success in this, what I had seen previously in the literature, was about every other person. So you basically take out a coin and ask the person if they feel lucky today. That's not a way to make a living. In terms of having a standardized way of success, it's process of elimination. What are the things that helped me? What are the things that made sense that would allow us to be successful? And so, it's a lot of trial and error. And I started to get notoriety. People started asking me to talk about these things. And I used to host courses to do that. And also hands-on courses in my office, just show them actually how you do it. And I think I've always been pretty generous about giving out the information, because I always thought, and that's what happened. It got so busy, really trying to write like a manual of how to do this. I think I told you, I used to go to the office at 4:00 in the morning every day.
Tell us. That's fascinating.
I would dictate from 4 to 7 every morning. And then I would send those recordings to a woman in Florida who would dictate them. And then we put this together every morning before the staff came, before we started seeing patients. So that took me like a year to put that that manual together that we've been editing or revising pretty much every session now for the last 20 years. And now it's digitized.
And for those younger docs out there who are like, why didn't you just use ChatGPT? Long before we had those amenities.
Way before that, there was this thing called Dragon Speak. And
I remember
it had a language, but it didn't have jargon language. It didn't have medical language. And so you had to teach it. So it was very primitive AI, but that's what I used actually 100 years ago. And it was, really frustrating. But anyway, it was good because you actually had to remember things instead of just looking things up. So it was a different time. Anyway, so we produced these manuals and produced this whole lecture series, and people would come to my office through these courses and they would say, well, I want to do what you do. So my practice was just limited to treating these things. And at the time, years ago, even your gurus in TMD stuff were general dentists that did this part-time. Very few had actually a practice limited to doing it. And 30 years ago, it just wasn't common at all. And it was mostly self-help stuff, like rub your face and do this and don't do that and soft diet and all this kind of thing, to pretty much to where you couldn't live a real normal life. So anyway, so I developed that and people said, I want to do what you do. So we started this concept of the TMJ and Sleep Therapy Centers. That was the name of my first office and still is. And we didn't really tell anybody about it. It wasn't anything I really marketed. I just was doing the courses. We went to a lot of different countries. We did them throughout the US and Canada. I spent 20 years doing courses in Australia. We did them in the UK, did them in the Middle East and Dubai. Now we're doing them South Africa. And everywhere I went, people wanted to do this. So we started adding them in different countries across the US. So for the first 10 years of doing it, I didn't really ask or tell anybody that was an option. And then about 10 years into it, we said, what if we just told people? Because we standardized the process. And so it was it was a whole nother manual just for how do you run a business doing this. And so I did that. And it's crazy. So it went from 16 in the first 10 years from not telling anybody to now, I think, over 85 now in 9 countries, just from telling people that we could do that. And it's funny how my life has evolved, because there was a certain point where it wasn't just practicing. I didn't have enough time to just practice. So I brought in partners and they helped me practice. Because at a certain time, I had to say, well, I only have X amount of time. There's only X amount of me. Yeah. And so I had to make the decision it became clear that if I worked 24 hours a day, 7 days a week, there'd be X number of patients that I could treat, right? But if I went and taught other people how to do what I was doing and set a standardized protocol and they followed it, they'd have the same result. That's science, following the same number of steps and coming out with the same result. So I realized that the more people I train around the world, the more people they can help. And so the more impact I would have. And so then at a certain point, I transitioned. And so then now at this stage of my life, I couldn't spin all the plates anymore. I couldn't run the practice. I had a clinic in the University of Tennessee, Memphis, that I was treating children at. I had an office in Dubai. I have an office in San Diego, traveling the world, trying to do all these things, write papers, do research from all our centers, because we have a standardized data collection system, which is unique in the world. We gather data in multi-center data collection sites where people are all doing the same thing, which is very rare. So I wanted to utilize that. And so now, at this point in my life, I've retired from clinical practice. I still do the mentoring and training, and I go to everyone's office, of which I'll be doing tomorrow. And my thing now is just keep spreading the word. So I brought on other people to help me. I have other educators for my domestic courses, and now I go around the world introducing these thoughts and finding partners. And it's really exciting. I look at it like I've had a blessed life. I was glad that I was sick early on, so I would know what works and doesn't. I'm so thankful that I was able to find some solutions that worked for people. And I'm just blessed to be able to do what excites me, which is continue to learn, continue to figure out newer, better ways to help people and share them with other people like you. And it's the best quality of life.
That's awesome. I'm so appreciative of you sharing that and of you on the mission that you're on, a few things I'm struck by, a bunch of things I'm struck by, but a few I want to highlight that I think are really interesting and just underscore. It seems everyone with whom I speak who has emerged to be a game changer, a life changer, who has moved the needle or moved the ball down the field in their particular discipline or passion, it stems from something personal, almost always, that there's something in their personal life that has impacted them to want to go in that direction, whether it be positive or negative, sometimes negative, and probably more often, just empirically speaking, in the discussions I've had with people. They always had a desire to learn, and they weren't satisfied with the answers they were given or were taught in school, or the dogmas of the profession, or the quote unquote religions, right, that you fall into in these kind of almost become a disciple of this particular mindset of practicing. And we all have it within dentistry, and then within each subset of dentistry and specialty, there are a myriad of those types of discipleships, right? And the people with whom I speak who have had the most impactful change, they have always thought, yeah, but now what? Yeah, but now what? What more is there I could be doing for these people? And I want to commend you for that, because not only did you uproot your practice and your livelihood as you're just starting a family. When I made my transition, we have a lot of parallels, as we said, but I got to do it when my family was well established and the practice had been successful for a great period of time. You're just starting a family. I mean, to make that decision is just amazing. And then we also have a supportive spouse who was there for us. As you're saying, she's bringing you food under the door and supporting you and your family. And my wife was the same way, supporting me in the decision I transitioned. And then you had a desire to help more people than you could help with your two hands. And that was one of the biggest things that motivated me. And I've told the story often, but it was hard for me when I transitioned out of my private practice. And I had a lot of parents of patients who were literally, and I'm humbled by this, in tears that I was not going to be able to do for their younger child, say what I did for the previous child. And as hard as that was, they were all amazingly understanding when I said, I know I might not be able to directly help Susie. That being said, if I don't go teach this and I don't go spread this word, there are Susies all over the place who are never going to get help. And at some point, I have to decide whether I just stay here and do this, or I go try to teach this on a greater scale. Because unfortunately, no one in the community that I was practicing, and still from what I've heard to this day, was practicing with that type of airway-focused, early treatment, holistic approach. And so that motivation to do more for the profession is something that isn't easy. And I think it's interesting. People look at it and like, oh, they just wanted to get on the big stage, or, oh yeah, now Steve's got all these centers around the world and Mike's got the podcast and these courses, lectures around the country. And hearing what you're saying, at least speaking personally, that wasn't my motivation. That wasn't why I did it. I knew I had to do a lot of this to get the message out, but the motivation is to change the lives of our patients. Do you feel similarly on that?
Absolutely. I think we all got into medicine, dentistry, because we want to help people. That's the kind of people we are. How we do it changes, and people were happy with what I did in dentistry. And I can relate. I was smiling a few times when you were relaying your story, because when I started the other practice just down the road, people would come back and go, "You can treat me though." And I said, seriously, I've retired from that. So it's kind of funny. And I remember that same thing happened when I retired from treating chronic pain too.
I'm
last
sure.
year. But so we all just decide how we want to do it. And it was a bit personal for me. I just wasn't happy. I wasn't happy doing repetitive things over and over again for the rest of my life. Quite honestly, it felt like I was in prison, and they were going to bring me rocks.
This is with when you were just doing general dentistry. You're saying,
okay, here's a pile of rocks. Here's your hammer. Okay, and when you're done with this tomorrow, we're going to do it again. And I really felt the need to learn, and so I really enjoyed that year of looking at this. And that's why my technique, I think, is a bit different, because I'm looking at it from a medical perspective. The teeth are not much of a factor in these medical problems. And they can assist. They're a tool in the process. They're not solely the cause. And so I did it to make a happier me, to feel more fulfilled, to make it feel like actually contributing more and doing something greater. And the way that you've talked about giving people their lives back, the thank you get for giving them their life back in what I'm doing now compared to what I was doing previously is just night and day. It's sincere. Thank you for changing my life, in many cases for saving my life. There's a number of patients I've had, we're definitely going to commit suicide. And you know that in this business, you learn, what the markers are. Anywho, it's the same thing. I just wanted to do something greater. I didn't have the goal of making all these centers and doing all that. I just wanted, I'll be honest, this is what I actually thought. I thought at 40, which was always my goal, was to retire. And so I was just going to retire and I was going to do this part-time and I'd ride my bicycle. I love to ride bikes. So I thought I'll ride my bike in the morning and I'll see patients in the afternoon and that'll be my semi-retirement and I'll do that for the rest of my life. Mm-hmm. And so that did happen for 2 months. And then I got so busy, I had to have associates and all kinds of people. And that went away very quick. But honestly, that was my goal at the time. And then everything just got it. You know how it is? Once one thing is that a new door opens and then you decide. And I also was smiling when you were talking because I was thinking that could get out of hand. And that definitely happened to me when I was trying to do everything all over the world simultaneously. And you don't think about it while you're doing it. And honestly, you take a step back and people go, oh, you create all these things and everything. Honestly, I don't really sit and think about that. I just think about just still doing the same job and meeting new people so you can open up new avenues and explore it and collaborate. To me, that's fun. And learning is fun. And people say, why don't you retire? You're 7 years old. I'm like, I think people retire from things they don't like to do. I just think, what a waste. So you and I spent our entire lives accumulating knowledge. So what are we supposed to do? Go stare at a tree and not utilize what we've learned and our ability? It's what keeps us alive. Yeah. And so I just couldn't imagine waking up and have absolutely nothing to do. That is honestly the scariest thought. So I'm having fun, and so are you. And you know what? That's going to keep the fire lit, I think, till the end point.
I feel so similarly on that. I love it. It's hard. There are other challenges versus being in private practice and head down that has a lot of, in running a practice that has a lot of challenges as well. These are different challenges. I just look at it as, this is my mission. This is my calling. And I don't mean that to sound cliche or woo-woo or, I really mean, this is what I really feel like I'm here to do.
I 100% agree. I know why I was put on this planet is the way I feel. That may sound corny, whatever, but it's honestly how I feel. I feel like I'm doing the most I'm supposed to do.
Yeah, you're right. And once you get that patient, as you alluded to, and I've said many times, I tell residents this, once you feel it once, you can't unfeel it. Mm-hmm. Once you help one of the, in my case, younger kiddos, and you have that parent in tears, like you have changed not only his or her life, but our family's life, like everything, because you took the time, and we're going to get into this in your diagnostics and process that you go through, to listen, to look deeper, to care. And I straightened a lot of teeth, and I'm blessed that I was a very good clinical orthodontist. I'm proud of that. And I really liked straightening teeth, and I really liked getting perfect occlusion. I liked that. And I was blessed to be very good at that. As rewarding as it is when that patient looks at their beautiful smile, and sometimes in adults especially come to tears, it still pales in comparison to when you have someone tell you changed their life because they can sleep through a night, because they're not holding their child's head up off the pillow to help them ventilate all night long, and then not able to sleep themselves and losing their job or losing their spouse or all of these things. And you're like, because you took the time to care. And I'm not saying, and again, just a kind of disclaimer out there, that I am curing and treating obstructive sleep apnea by what I do. That's the whole point, is that's not what I'm doing. And that's why we have to get away from that. And we'll talk more about the X's and O's in a moment. It's that I took the time, and you alluded to this, to dig deeper. I didn't just look at their crowded teeth. I didn't just look at their constricted arch form or their steep mandibular plane angle. I looked at them as a patient. I took time to dive into their history. When all the consultants were telling me, you're spending too much time in your consult room, you make your money in the back, get out of there in 2 or 3 minutes. And I said, but I can't connect with them and figure out what's going on with these children in that amount of time. Now, we have a garden variety class 1 occlusion where a little crowding comes in and they have a clean medical history and you go through your questions and everything's fine. You don't need to make more out of something than it is. It's not, this isn't an everybody problem. The trick is if you're not a good diagnostician and you don't understand the science and the medicine behind this, you don't know who's who. And so you just throw that big net that you cast out over everybody and you scrape it all in and you hope you've caught enough good results. And it's not easy. And that's the next thing I want to talk to you about. When you go through this shift and you have to question the way you've done it for all these years, and you have to look at your failures, and you have to look at the patients you missed it on and you didn't manage the way you now know how to manage them. How did you reconcile that? Because I feel like that's a really hard thing for our colleagues to realize, oh my gosh, what I've learned and what I've been doing. And I want to use the word wrong, because it's not this intent that you have to do things incorrectly. It's just not the best approach for many of our patients. So how did you figure that out? And how did you reconcile that in your own head, in your own space, to be like, I've been doing this for 14 years and I'm not doing it technically correctly?
I still have that idea. Right before this podcast here, I was doing a presentation showing some cases I did 25 years ago. And the point was to show how easy it could be now. And so you always look back. What I always tell people is you always had good intent and you did your best with the knowledge base you had. So you can't feel bad about that. It's just that history helps you make better decisions now because you can see what worked and what didn't work. And that's the problem when you come out of dental school. You're so full of yourself and you think that you know everything and you don't know anything and you don't know what works or doesn't. You just know what people have told you. And quickly you find out what reality is. And so on that aspect, I don't think anybody could feel bad, but I think it's a constant evolution to improve and be better. And my philosophy in this whole concept, because I look at it from the patient's perspective. So I keep refining my techniques to, in a way that is, how little do I have to change things in order to eliminate this bad outcome? Like how little treatment can there be and how easy can it be in order to have the most effective and comprehensive result? Not the more things. The way I look at stuff is if you get a really good grasp on something, if you truly understand something, it's simple. It's the ones with all these steps is the people who really don't understand. I always equate it to Einstein. How many calculations did it take to summarize E equals mc squared? Probably took 20 chalkboards of calculations. But then when he finally understood it, it was quite simple. And I think that's what I'm looking for is how to get to the root cause, the origin, and how minimally do you have to make changes in order to end up with a better result than you can do mechanically or other ways. So I'm always looking at how little, not how much. And it's amazing nowadays that we've got the technology and the knowledge base to understand all the things that are comorbid with each other that we're affecting. So I appreciate your comments about how you have seen that with the families, because if you just look at it genetically, you're not just changing that one kid, you're epigenetically changing their offspring. And just as their parents epigenetically altered this offspring that you're treating, you're undoing a lot of things. And so we got to look at it generational that you're affecting, not just the kid, not just that family, but their kids. Yeah.
That's such a great point and so true. And in the realm of how you're figuring out and to simplify all of this, and I love your analogy with Einstein, I find the same thing. Sometimes it gets really complicated, oftentimes, when you focus differently and you shift the paradigm or the realm of where you are at any given point. It's oftentimes very confusing and chaotic initially as you're trying to assimilate all this information and isolate and distill down what is most important. And I agree with you. Then once you figure it out, it's really not that complex in terms of you can start to see patterns. And when you go through the diagnostic process, certain things stand out and jump out as really being red flags, and you start to recognize, wait a minute, this is related to this, which is related to this. So what is your process that you've developed as you studied for 14 hours a day and locked yourself in your office for a year essentially to do this, and we're just building the new practice and starting to incorporate these concepts? What has that led to today as far as and I know it goes well beyond the scope of today to go into the details of all of your diagnostic processes, et cetera, but when you look at a patient, what are the key things that you're looking at? And you've alluded to the medical side of it before. What do you mean by that? A little more specifically, what are some of the biggest red flags? Are there any canaries in the coal mine, so to speak, that when you see this, you're more worried about this? And I know this changes based on how that patient presents to you, if they're in a more acute pain situation earlier on versus a chronic long-term pain, or the etiology of the pain. But if you could just try to simplify that for us a little bit and distill that down, that'd be great.
Okay. Instead of primary focus on an orthopedic part and doing more and more invasive things, which doesn't make sense, whether it be the jaw joint, spinal surgery, cervical fusion, and all these kinds of things, it just seems to me that if you do more and more invasive things on a particular area and you don't resolve the symptom, shouldn't there be a red light that comes on in your head somewhere that says, maybe I don't have the right part? Maybe this is a compensatory issue, not a primary issue. And so I think that's primary for me, okay, is finding origin. So my system is not based on microscopic evaluation of an area. Mine is looking at the whole body, but primarily it's a system based on neurology and functional breathing. Because every injury, every physical injury is an injury to the nervous system. And the longer you have pain, the amount of perception of pain increases. So the more you have inflammatory neurotransmitters that are depleting your magnesium from your receptor sites in your trigeminal spinal tract nucleus, they all come together basically in your neck. So if you have a problem in your head, it has to go down your neck before it synapses and ascends up to your thalamus and out to your somatosensory cortex. So you're getting impact from your sensory nerves in your neck. The trigeminal spinal tract nucleus goes down to about C4 on most people, C7 on some. So you're getting all this neck stuff coming in with head stuff, and it all gets confused, okay? And you have to understand how to triage that. Because there's no problem in your jaw that doesn't affect your neck, and there's no problem in your neck that doesn't affect your jaw. How do you separate those? And so there were certain points in my life where I came in contact with someone who actually had a system. And it was obvious. You know, when you're looking for something, you just don't know what you're looking for. But when you find it, you go, that's it. That's the missing piece. And so I met a man, an orthopedic surgeon. He was giving a presentation at the American Academy of Craniofacial Pain at the time. And it was brilliant. He was explaining how to separate orthopedic injury and the neural consequences. The injuries that produce a dystrophy, central sensitization, is when your nervous system actually changes into a sympathetic state and doesn't have that balance between parasympathetic and sympathetic. And so you have a whole different set of symptoms. So instead of just it hurts, you now have all these autonomic symptoms, okay? And how do you separate those and how do you triage? Because if you actually knew how to do that, then you would know when you're making people better, not just from the orthopedic part, but from the nervous system part, okay? And when I came in contact with that was a huge revelation for me, because that, for the first time, I could see how I could identify. I could triage an orthopedic problem from a neural problem, and then I really came to understand how respiration affects posture, affects orthopedic issues in peripherally. And so by the use of this evaluation, orthopedic neural evaluation tool, which is called motor nerve reflex, so it's autonomic motor nerve reflex testing, which is what was taught me by John Beck. And I now teach that with Rocky Romano. He's an orthopedic surgeon in Chicago. And we're doing our validation studies using heart rate variability right now. So we hope to publish before the end of the year. But it's something I've taught all over the world because nobody has that. I've worked with all sorts of rehabilitation people, so chiropractors, physical therapists, osteopathic physicians, orthopedic surgeons, you name it. And really what most people do is they treat whatever the person complains about. In dentistry, I say this tooth hurts. Somebody's going to do something about it.
But orthodontics, crooked teeth.
But it may be
you're treating the teeth.
Yeah, but it may be just a symptom referred from somewhere else. And in the same way, if I have a low back issue, somebody's going to fuse it, whatever. They're going to keep doing treatment, but it doesn't get better because we don't realize the problems at the opposite end of the spine. Okay. And so this has really helped me triage and have way better outcomes because I understand that a problem in your foot can make you have face pain because you're walking around all day or a bad back. How would you know that's not stress? That's not. So I have a way to separate these things. Okay. And the respiratory component is really important because I learned that you can't heal if you don't have restful sleep. So what makes you not have restful sleep? Pain. 50% of insomnia is the result of chronic pain because you're producing all this cortisol. You're trying to go to sleep and you can't go to sleep. But there's also other factors like you can't breathe. And if you can't breathe, your brain knows that too, and it won't let you go to sleep because it knows you're going to stop breathing. So there's all these protective mechanisms and all sorts of other things that wake you up at night and medications that you're given for this bad sleep that then now screw up your sleep even more. Like, all of the antidepressants and centrally acting drugs, they shorten sleep time, they lighten sleep, and they decrease REM. So now we can't remember and we have more disturbed sleep. We're more dependent on the drugs. There's a whole cycle of stuff you have to look at. But to me, it's triage everything. I know you're waking up at night, but why? How much of it is respiratory? How much of it is pain? How much of it is your medication? Actually find reasons for all these things. And to me, I've got to have a legitimate good reason, a good process. I don't want to just do something and cross my fingers. Like, I hate that. I want to actually know what I'm treating. And therefore, I'll know whether I was successful or not at it because I've isolated it. So I have to say the two biggest things for me was the understanding of the respiratory component with facial pain. And the other was the neurologic consequences and triage of orthopedic injury. Those two things, I think, separate our game and understanding that it's impossible to separate chronic pain, facial pain from sleep breathing disorders. And I've said that. I was showing the slides just a few minutes ago before we did this. And I'm going, I made that slide 25 years ago and I'm still using it. The only difference is literature has up to what I've been saying. And now,
funny how that happens.
Now there's sound evidence because before I was a lunatic, which probably people still think, but now at least there's validated science for every single thing I said, and that I found that works. And that's the one thing we've been able to bring to other orthopedics is that the understanding that respiration affects balance. They're trying to get people upright, but they don't understand they can't breathe. And they never really equated those two things. And so now we're starting to see that. It's so nice that everyone's starting to understand that breathing is important because 30 years ago, it wasn't important if you breathed or not. No one ever checked it. No one cared. There was no class in dental school 50 years ago when I was there that said people should breathe. Now, there was
even today. I would.
Oh, okay.
I'd be willing to say, I can't say that with 100% certainty, but I don't think I deal with a lot of residents and young docs, and I get the same question from every one of them. And that is, why weren't we taught this in school? So it is certainly still pervasive. And actually, I'd love to hear your take on that. Why aren't we learning more about this? And what are your thoughts?
I tried to do that. I tried to introduce that right,
because you just said in Tennessee, you were saying before you had the center there.
I tried to do that. It's really how things are laid out because how a school gets their accreditation is by the curriculum that's allocated to different subjects that somebody decided were important, who stopped doing dentistry years before and became a politician and decided these are the important things in dentistry because maybe that's what they learned 50 years before, okay? And they don't practice and they don't really understand what is valuable in these connections. And the fact that you figure you have X amount of time with a dental student and the thought is that you have to take something else away if you're going to introduce something. That's not true. You can combine things and have a much better. So again, you'd have to change the education system from the top. You'd have to change the allocation. They did that, about 7 years ago when they introduced sleep as a basic component of undergrad dental education. You're not given a great amount, but before that, it didn't even exist. And so the understanding that should be a much bigger. I wrote a little review of a book years ago by, Peter Sestouli and Levy, who was the dean of the University of Montreal Dental School. He's one of the world experts on bruxism. And they came out with a book years ago. And my critique of the book, they wanted that for the Journal of Orofacial Pain, a book review. And I said, the understanding of the comorbidity between these breathing disorders and jaw joint dysfunction is not represented in dental schools, and in my opinion, should be taught with the same amount of emphasis as operative dentistry. Because come on, operative dentistry, we have milling machines now that can outperform. I envision the future as strip malls with people walk in, get screened for caries, and then a dental technician is setting them up in a machine that mills it. We're already there. Yeah. So if that's all our game is, it's now a time of separating dental technicians from dental physicians. Okay.
I love that.
And I have been to, I didn't coin that. That's a book from Alroy Fonder. I can take it here off my shelf. Back in the 70s, that was the title of his book. But you see this all over the world. In Australia, I spent so much time there. That's where the dental technician really got generated, okay? Because they didn't have enough dentists 20, 25 years ago. So they now instituted this, because they would import them from Commonwealth countries like Canada and UK and stuff. And what they did is they have all these rural areas where they didn't have enough dentists, and they didn't have enough dental schools to make more dentists. So they made dental technicians that they taught them how to do operative procedures and remove teeth and stuff like that. And to the point where they can practice alone. And those came from places like Alaska, who we have similar programs there and similar delivery systems. So that already exists. And we have denturists, we have those kind of basic function things. They're already in place. This is the time to make the change.
I agree. And what's so amazing to me, though, is on the organized dentistry side, we're fighting that. So much of our organized dentistry so many states are involved in fighting legislation to expand the duties of someone who would be in more an auxiliary role, right, or a technician role. They're protecting their ability to do this symptom-driven treatment that we could, and in time will be taken over by others, or robotics or technology, AI, whatever the case might be, or all the above. It's like, isn't this the perfect time for us to regroup as a profession and say, we are on the precipice of something huge here? And yeah, we know we went to school for all these years to learn how to straighten teeth, or to learn how to fill cavities, or to learn how to do a crown prep. That being said, it has made us incredibly myopic and incredibly focused on one very small area of the body. And we have led ourselves to believe that this area of the body, and okay, we know, yes, with perio and the crossover between bacteria in the mouth and heart health, cardiovascular health, systemic bacteria, we kind of like loosely dip our toe in the water of this systemic connection to the mouth. And even the ADA and our organizations will talk about it. They'll talk about, yes, we're physicians of the oral cavity, but we don't back it up. At the end of the day, we're fighting to just remain technicians. And I love that you called that out, because I hadn't thought about it in that way. I've always thought, yeah, we're the ones trained to do these tasks, so it should be us. If we're still doing those tasks, then who is looking next level? Who is looking at the medical comorbidities? Who is looking at the overall health of this patient if we are still with our heads down, buried in a patient's mouth all day long?
Chasing symptoms. That's it. That's really it. Instead of finding origins. It's like our specialty of pediatrics. So I started in the clinic in Tennessee in the pedo department and trying to introduce these concepts, because what specialty of dentistry would be more in tune? Supposedly the specialty of growth and development, who doesn't get any training in growth and development and interceding into these respiratory problems and other kinds of issues that their patients have, because we know it's standard. 1 in 6 patients, whether you're a child or an adult, have some kind of orophacial pain problem and breathing problem. They go hand in hand. And so they're taught operative dentistry, sedation and major operative procedures. That's all we got. To me, we have specialties that outline what their duties are, but we don't train them for that purpose. And that's maddening to me. It's maddening to me. But I agree with you. This is the time. This is the time to revamp everything. This is the time to go, you know what? Dental schools they're going to have education for dental physicians. If you want to do that, if you want to be a dental technician, we have a program for that. You want to be a dental hygienist, we have a program for that. Like, why not? You know?
Yeah. I mean, so much of other medicine.
Yeah, the dental technicians, they'll run the keyboard that runs the milling machine, but the dental physicians will actually go, hey, because in Europe and here, it used to be, we were all trained together. Medicine and dentistry all shared the same first few years together before we split into our specialties. In Italy, dentistry is a specialty of medicine. You have to be an MD before you can be a DDS.
I didn't know that.
Orthodontics is a subspecialty of dentistry. Okay, so the orthodontist, I have friends in Italy. I've been spending a lot of time there and doing some teaching and things with the orthodontic field. And so it's very different to have, and because other dentists in Italy, they're not MDs, or if they've gone other programs and stuff, because now they're starting to shift away from that. So now they have limited ability. So the guys I work with are still MDs, so they can take full head x-rays, they can do evaluations, they can treat a whole person, not just a mouth. And those are the people that I really relate to, people with your thought process that, you know, hey, this is just the thought process that this isn't connected to anything else and doesn't have any other interaction is moronic. And but that's the way we're taught. And it's not helpful. It's not helpful to the patient. But this is the time. I couldn't agree with you more. That now is the time. My goodness, if we haven't learned. And we're still fighting over fluoride. We're still fighting over mercury filling. Are you kidding me? 2025 and we're still doing that? It's like,
But just like in ortho, we're still fighting over extractions and we're still fighting over phase 1. I'm looking back in the literature and I was just looking through for an article I'm writing, and I was looking through. There are articles in 1912 and 1913, some of them written by physicians who were calling out the orthodontists. Our profession was like 13 years old, calling out the orthodontists, and at that time they called them rhinologists, to today's modern day ENT, otolaryngologists, to work together to solve this problem called mouth breathing and the impact it's having on both craniofacial growth and development and neurocognition and behavior. I'll send you the articles.
1800s. I've got articles in the 1893. We've got articles exactly the same thing as you're saying. Yeah.
You're looking at this saying, like, can we still be arguing about this over 100 years later? We are fighting this. And I think a big part of it, and in my opinion, I'm not putting your words in your mouth, I want to hear your take. I feel a lot of this is follow the money. Follow the money. You alluded to the fact early on that it wasn't easy to start a business or create a business model doing this new type of dentistry, right? This is not the typical drill, fill, and bill model that is in general dentistry, or in my orthodontic world, the sort of straighten and bill model. There's not reimbursements right now on the dental side, significant ones that I'm aware of, especially in orthodontics, for the diagnostic process. There are some potentially, but not at the level that you're going to get for a full case of ortho. So I hate to be so cynical. I just try to call balls and strikes on this stuff and say, you're going to go for what you get paid to do. And you went to school, you went into nowadays a ton of debt. The average orthodontist now is coming out over $500,000 in debt average. And they're not going to go and sit there and say, I want to take an hour, or not even necessarily take that long in every case, but I want to take all this extra time to diagnose, right? They go into a practice. Maybe they're working for a corporate, maybe they're working for an established doc who has a couple offices, and say, hey, let's put a CBCT in every practice so we can really dive deeper into our patients' overall health and wellness. There's no money in it at this point. And I feel like that's a big problem, because until we get the political system to incentivize, and this is medicine and dentistry, Peter Attia talks in this in his book Outlive, until we get the medical and dental system infrastructure from above to start rewarding diagnostics at least on the level of, if not greater than, treatments, I don't know how it ever changes. Again, I don't mean to be cynical on that. I don't know. And I'd love to hear your thoughts.
Yeah, that is the orthodontic model, right? Is get them in for an exam and start the case that day.
That's same day starts.
That's the ortho model. Yeah, I'm quite familiar. But the thought process, and you're 100% right, general dentistry as well, especially, they come out, they're in debt, they want to start making money. And there's a lot of other factors too. I see people not wanting to be entrepreneurs. They want a job. And I think most people, young people nowadays seem to, I don't paint everybody, but seem to want the work to play. It isn't my generation, which is, I'm going to build a practice, you're going to do all this, blah, 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 blah. They don't really want that responsibility and all those headaches that come with it, as we both know. That's part of it. But the other part, as you were saying, is, and that's why what I do, because nothing I do is really dental. We build medical insurance, okay, if people want to do that. And I even built a medical billing software years ago. Boy, I don't have a boat, but the way people talk about boats, that would have been my boat, a hole that I throw money into for I don't know how many years. But it was effective, it worked, and I just couldn't continue because it had a niche market with just the people in this world that would utilize that. And so we have that in place. And medical billing is very different than dental billing. Dental billing is associated with a service. You did a service, you get paid. There's not really much diagnosis involved in it. Whereas medical insurance, you have to have a code for the symptom for which they're seeking care. And then you have your billing code for your examination based on your symptom code. And then if you prescribe imaging or whatever tests, those are connected to your exam code, connected to your symptom code. And then you're going to come to a treatment plan. And that's based on all these things in this order. Okay. And it's very logical. It makes perfect sense to me. Dental insurance is not like that at all. But in this way, you can follow back. What is it that you were doing? And the way I teach, a diagnosis should be based on the symptom complaint, right? And so everything points back using the same thought process. What we were trying to do, and what some of us have been successful in, is getting treatment for OSA, especially in children, through medical insurance. Because that whole two-phase thing is where orthodontists really don't want the first phase, because they know that maybe it's dental insurance, whatever, they only cover one phase. And so they don't want to go there and go, I'm going to charge you for this, but then your insurance is going to cover that. I think that's part of the financial things you're speaking to.
You're 100% right. I hear from all the time from people that is literally, don't burn out their ortho benefit in phase one. I hear it all the time.
There you go. My thought process was, what if the first phase is not dental? What if the first phase is medical? What if you're actually treating a medical problem like I do? I treat facial pain. Chronic pain is a medical problem. Not breathing while you're unconscious is a medical problem. So if children have that and you have it documented, now your therapy is for a medical problem, phase one, and then aligning the teeth is the orthodontic phase, build dental insurance. So medical insurance, first phase, dental insurance. That was the model that I was teaching, that I was trying to explain to people. But you have to have documentation. The only way you're going to know that is if you screen for sleep breathing disorders. Right. And if you screen for them, we have a paper that's being submitted here that we did with Judy Owens and Harvard in combination with the ACP who funded that, where we took 12 offices across the country that then tried to find craniofacial relationships that might be related to sleep breathing. And you know what the number one correlation was? And this is not a difficult thing.
As far as from like a skeletal component or malocclusion component?
Just a visualization of skeletal and oral and postural evaluation. What do you think was the most correlated to a sleep breathing disorder?
Torn between transverse deficiency and vertical facial growth, and then closely in there with a curvature postural of the C-spine.
Yeah, so posture was the number one correlation. Okay. And then all the other things you were talking about. And that includes tongue tie, that includes midface deficiency, that includes all the things, asymmetries and malocclusions, open bites. Looking at all these different things, posture was by far great. So these are not difficult things to integrate. And that's what we're trying to publish now, because
I'd love to see that.
To try to get to, because it was actually came from a presentation I did when we were at the university, and I would hold these symposiums, pediatric symposiums on OSA, and invite in all the top people. And so we showed a case. We had this obese 10-year-old that the pediatric hospital had sent over. She'd been on CPAP since she was 5. She was 10 now. A BMI of 42 or something. So and she had an AHI of 118. So they wanted to see what I could do with that. And using a tandem technique to protract the maxilla and not have any face, but I don't like external leveraging. But we showed how we were able to move the maxilla forward and hold at a phonetic position that I published, how to open the airway. And in 8 weeks, we showed that we took the AHI from 118 to 3, got her off CPAP. And those physicians were blown away from that.
Yeah.
Judy Owens from Harvard, she's a professor, but she also is the head of Boston Children's Pediatric Hospital, the sleep component. And she said, Steve, can you produce a visual screening tool of what kids who have this? Because I'd like that. I would like to publish that so I can give it to my residents so they'd know who to refer to a dentist.
Yes.
And I go, Judy, that sounds great, but we have one problem. Your assumption is you think all dentists are trained on how to treat pediatric OSA. And I go, the things I'm showing you right now, like, how many dentists know that? So then she said, who else could we use this for? I go, we could use this for dentists, because dentists don't know what kids' mouths look like that have OSA. And so that's why it's taken us, 6-7 years now to finally get the data together and publish it, how long things take to come into print. And so finally, but what simple things could we do that then would give us the evidence then to go to primary care docs to request a sleep study or whatever, a home sleep study, whatever. There's all these different techniques. But now you'd have a medical problem that you could bill medical insurance for that would cover your orthopedic techniques. And then when you're done with that and you've resolved or made better that issue, now it's time for the orthodontic. That was my way of approaching that.
Oh, it's so brilliant. It's so funny. I've thought about a lot of this and how we approach this. And sadly, the AAO went in the opposite direction 4 years ago, maybe it was. And they cut the phase 1 codes and that's just what we want to be doing, is minimizing any incentive for docs to be billing for phase 1, cut the interceptive treatment codes. And really disappointing and discouraged that they did that. And so I've been thinking about ways to do this. I love that. I love that approach, that we're not trained in that, and not even as orthodontists, meaning, okay, so what are we even looking for? And that's my wheelhouse and passion. That's what I'm teaching. I have had so many residents of this last class that graduated reach out to me, one just 2 days ago, and said, thank you for showing me what you showed me. At the time, it didn't make as much sense because we weren't seeing a lot of young patients, because that's a whole nother problem we could talk about in orthodontic residencies. They're not seeing or treating young patients. And if they are, because of the way the billing is with the Salzman index, it's not a handicapping malocclusion as determined by the state paying for, if this patient is on state funding, and even some private plans now, they won't pay for their treatment if it's not bad enough. So they're literally just looking at the teeth in these younger kids. They're not looking at anything more than that. So what do you do in an orthodontic residency? Kid comes in, if you're lucky enough to even get them in at 6, 7, 8 years old, you look at the teeth, there's no noticeable cross bites. You basically can't really do much, and you might have moderate to severe crowding in both arches. That sets up as a serial extraction case, because guess what? They will pay for you to pull teeth on that kid as many times as they need them pulled and as many as they need pulled. And they will pay for the orthodontics when everything is now a mess and you have to fix it when that child is closer to adolescence and the permanent dentition. It's a problem with the system. So these residents have reached out and said, oh my God. And it's funny, Steve, because this is what helped me wake up to this 20-ish years ago when I went out into practice. And I'm like, all of a sudden, these kids that are coming to me aren't older kids, they're younger kids, and their parents want something done to prevent major problems. And I don't know what the heck to do except tell them they need teeth pulled. And I'm looking going, but this isn't a problem of big teeth. This child does not have big teeth. Like, why am I solving this by removing tooth mass? Much like you said, I like to try to find a solution that addresses the etiology, not just the symptom. And extracting teeth of normal sized teeth, you can't even argue that doing that is treating. We can have debates on what to do and how to treat. What I'm saying is if that patient presents with significant crowding and their teeth are normal size, their jaws have to be too small. It can't not be that. So why are they so small? Why are they growing this way? And then that opens up Pandora's box where you start to have all these questions. And these residents have said to me, I didn't realize how many kids would be coming into my office every day that were exactly what you were describing to me. And I now know what to do. And by what I had taught them, they understand how to diagnose this and detect this and communicate with the patients and the parents and communicate with the medical providers to be able to start to address this. But if we don't change that system, I don't know how we ever can get the profession to change. I really don't, because we're so focused on just the treatment.
Yeah, I don't know that we are, for a lot of reasons, in addition to politics and all kinds of things, that the things that you've mentioned. Yeah, so I gave up on that thought process some years back because of just frustration of just banging my head against the wall. And it became clear to me that the way to make things change in the way that you and I are speaking is by demand, is by patient demand. Because you said the parents are bringing their kids in. They know something's wrong with their kid. They're just frustrated that they can't get somebody educated enough to help them with their kid. So the demand is there. But I think the demand for specialized education, we've had this conversation before. I'm old enough to say that when I came out of dental school, we didn't wear gloves for every procedure. We just washed our hands all day long. And if we had a surgical procedure, we'd put gloves on. The most part, regular operative stuff, we just used our hands. And until one day, until HIV appeared. And then patient would call up and everything changed in a day. Patients go, does doctor wear gloves? If he doesn't wear gloves, I'm not coming in. And that changed everything. It wasn't our ADA. It wasn't any other professional organization. It was people demanded a change, and it changed, and we adapted. In the same way, I think we need grassroots to just continue to say, for people to demand a level of care that clearly is not working. And that argument about extraction or non-extraction doesn't really affect airways and all that kind of stuff. There's truth to that because it's a skeletal problem. And you're not doing anything about the skeleton. So plucking out teeth doesn't change the airway. It was just as bad after as it was before. You didn't, I get that. But at the same token, even in the orthodontic literature, AGODO, orthodontics only lasts 8 years. And even if you use wire retention, it will not last. It is a temporary treatment. So I don't understand why, orthodontists are upset that people go to strip malls and get their teeth straightened. It's a cosmetic procedure. It's not affecting airway in that way. Now, if the orthodontists wanted to treat as physicians and actually address the respiratory component that they couldn't get done at the strip mall, now you're talking about why a professional needs to do it and not, you can't get that treatment going to a strip mall and do aligners. Okay, that's all cosmetic stuff. But what's the difference if you do cosmetic at a strip mall or do cosmetic at a specialist's office? If it's all cosmetic.
So true. It's so true. It is so true. And I say the same thing to my orthodontic colleagues. And I'm like, you get critical of all of these quick fixes, but you do it a lot of times and you're not looking deeper. And people get worried in ortho about the GPs are starting to do the Invisalign, and gosh, the pediatric dentists are starting to do more phase 1 and early treatment. And there's chats in our ortho groups all the time, or they're not trained in this, or I'm the specialist and I'm training growth and development. And I'll say to them, what are you doing about it? Are you just putting that kid on watchful waiting? Are you sending them down a serial extraction pattern? Are you taking CBCTs young and looking into the airway? Are you working with medical providers? If you differentiate yourself, we have the ability. Everyone is so worried when everything came out with, was it Smile Direct Club or whatever, that's now out of business. But and I'm not saying that we shouldn't be trying for consumer protection for things like over-the-counter aligners that could cause harm. Get that. That's not my point in all of this. My point is, but the point is, if we are so hyper-focused, we were so bristled by this company coming in and just straightening teeth. And I was saying to people, and I would say to residents when I'd be teaching, I'd say, why don't we just focus on being better than that? And doing more for our patients. And if a patient, yes, there's always going to be a patient who just wants a quick fix in any realm of medicine, dentistry. It's never going to go away. That is going to be so few and far between. Whereas the majority, especially when you're talking about young kids and their parents, a parent is rarely going to go get it. They might for themselves, but for a quick fix for their 6-7-year-old child or 4 or 5-year-old child who can't breathe and is growing in a way that doesn't quite look right. Because as you said, the parents know something is not right with this child, right? They look at their friends, they look at other kids, they look at pictures of their child next to others, like, well, something's not quite right. The parents know oftentimes. When you then show them that you're so much more than a tooth straightener, I had so many physicians bringing their kids to my practice and people within the community who they're like, we've heard you just do this differently. I didn't advertise it. I didn't market it. I didn't ever promote, I look at Airway. I literally just said we have a more whole patient approach here. And we're going to try to find out the why.
Build it and they will come.
Yeah.
Right?
And it was like patients were just craving that because we're not given that enough. It is frustrating. I guess as we wind down in this, what do we do from here? Because I know you had an experience which you touched on where you tried to do something in Tennessee and it was not viewed favorably and was kind of crushed and turned away. I have met tons of resistance and I get it. That's why I'm on this journey, is to fight this fight. And I expected and I anticipated a big fight and I can handle it. I just sometimes am shocked that as much as we're making progress with the young docs, and I love your point about educating and creating a public movement of the kind of that we can take it again, not to be political on it, but the Maha movement, right? The Maha moms. Why is there that? People have painted it to be this political thing. No, these are just moms who want their kids to be healthy. Let's just stop and cut all the other nonsense out about who's doing it. We want our kids to be healthy. So if that is what we all agree, I don't think anybody out there wants their children or someone else's child to suffer or not be healthy. And I really do believe my orthodontic colleagues who don't like a lot of what I say or what you would say, it doesn't come from a bad place where they're like these bad people who don't want kids to be healthy. It's just very threatening to them. And there's a lot that they weren't trained in it. There's a lot that goes into it. But how do we get people to start to not only the professional side? So because I hear this a lot from parents, they reach out to me and they say, I've been to 4 orthodontists, or my general dentist said this, right? My pediatric dentist said this, my orthodontist said this. I'm getting all these different opinions, and the majority of people are telling me just wait, or they'll outgrow it, or all the things that they tend to hear. How do we, because if the demand can be there, but we've got to get a way to educate our colleagues on this more. Do you have any thoughts as an educator, as someone who's so fully immersed in this? I mean, how do we penetrate through that shield that is being put up to us educating on this?
So that's why I've been hosting courses for 25 years now, trying to find these people like you and me. I don't think we're representative. Clearly, we're not representative of all the dentists, orthodontists, and all their specialties. We have a special passion. My thought is I'm going to express this point of view and identify those people wherever I go who that makes sense to, that this answers their questions. I've told you previously that the things that didn't make sense to me when I was 20 years old in dental school that I was told still don't make sense to me today. And now we have actually answers for those things. And so I think having that rational, everyone hides under we've had this conversation too, hides under that's not literature based or whatever. And this whole concept of only things that we did previously are valid, nothing. So there's no growth. So there's no possibility of learning something new is moronic to me. So again, what people have done in the past has put together affiliations, academies, things like that. There were things at one time where we had this kind of thing where we could point to people. But the way I would do it different if I was setting up academy or affiliation is I wouldn't limit it to just professionals. I would limit it to lay people. I would open it up to everyone.
Interesting.
Medicine, dentistry, lay people. I say, let's all get together because it's in my experience, when I do a presentation, it doesn't really make any difference if I'm talking to dentists or talking to lay people. It's not like dentists have any more knowledge on the things we're speaking of. Physicians as well.
Fair.
I could have an astrophysicist in my chair, but if they don't have a background in what I'm talking about, I have to speak to them at an 8th grade level. And that's what we're taught to communicate. So I think everyone has a basic lack of knowledge. And what if we got everybody together who says, I'm interested in this? And I loved, you're so right on. People just want their kids to be healthy and they themselves want to be healthy. So an organization that was open to that and had great speakers and had it open for communication and get enough people to ask, why aren't these things this way? To where then maybe this could then funnel to political representation and other kinds of things where you actually get support. Again, I think it has to be grassroots. I'm doing my little bit. It's a tiny little nick in this huge glacier, but it's not enough. I realize that, but I take solace in the fact that people are getting helped. But the greater good of let's just change what we know doesn't work. Man, now's the time. I'll go back to what we were saying earlier and maybe create that affiliation. So maybe that's a conversation for you and me to have another time where we go,
I think
let's problem solve. Let's bring some of the people that you know, some of the people I know that are motivated and get them in a room and go, hey, how can we make this happen? I think that would be the start.
I love it. And I'm in. We are going to have to, I mean it, we're going to have to communicate on that. I think that is brilliant. That's the first time I've ever heard anybody say, let's widen the tent. Let's make the tent bigger and bring more people in. Usually these associations and societies, they tend to want to narrow it in on specialists of specialists and make it an elite phenomenon. And I'm not being critical of that. It's just there's something to be said for some of that. It's just I don't feel like that's the solution for this. I completely agree with you. This needs to be a big, broad, wide open tent with structure at the top, but with open forum discussions, leadership, and really start to break down the walls and the barriers. Because as much as you have done, you're right. And it's not minimizing it to say it. It's still only one blip because it's just one part of this. It's huge. And the number of lives you're changing is phenomenal and amazing. It still isn't going to move the needle enough to enact the change we need. We need something big. We really do. We need a movement, and I love it. And I love incorporating the lay people. So you and I need to follow up on that. Well, this has been amazing, really amazing discussion. How can people, if they want to reach out to you, learn more about what you do, the TMJN Sleep Therapy Centers, what's the best way for them to follow you, find out more about your content, what you're doing?
Yeah, our website, TMJ Therapy Center, CENTRE.com. And that hosts all the information about the things we're doing, all of our centers around the world, our education courses that we're doing all around the world, and literature, all kinds of things, videos, information, stuff like that would be a good place to start. And then just reach out to us so I can answer questions and kind of point people in the right direction.
Oh, it's so amazing. And I so appreciate not only your time coming on, your expertise, your knowledge. I'm grateful, as I'm sure, and I know many patients are, that you didn't just resolve yourself at the age of 40 to riding your bike in the morning and doing dentistry in the afternoon, because you have changed a lot of lives. And the fact that many decades into your career, you're still this passionate and this motivated to change, and that you feel it's your calling, is so evident and so remarkable. And I just thank you for what you're doing. And you got a friend in me. If you need me, reach out. Don't ever hesitate. And I really mean it. Let's try to think bigger and maybe combine forces here to see what we can do.
Well, thank you. I appreciate that. And back at you. Let's do it.
All right. Thanks so much. Dr. Stephen Olmos, thank you so much. It's been an absolute pleasure.
Been mine as well.
All right. Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.